So we're going to transition now to our national presenters. And I will tell you, we are very, very fortunate to have these two very prominent figures in Washington, D.C. here to speak to us so that we can learn more and gain some insights into how the work we're doing here in California fits into the national scope. So if you all would come on up. As they're coming up, I'm going to quickly give you a couple of housekeeping items. I always get lists to tell you about. So if you'd like continuing education credits, go to the registration desk. Lunch is going to be outside. And then join us for a reception this evening in the Palm Court, which is over by the pool. And of course, please remember to fill out your evaluation forms. So I'm going to introduce our two speakers, and then I'm going to go sit down so that I can listen as well. The first speaker is Charles Ingoglia, mostly known as Chuck, who's the Senior Vice President for Public Policy and Practice Improvement with the National Council of Behavioral Health. It's always fun to read people's bios, because even if I've known people for a long time, I learned something about them I didn't know. So before joining the National Council, Mr. Ingoglia provided policy and program design guidance to the Center for Mental Health Services at SAMHSA under the U.S. Department of Health and Human Services. Earlier in his career, he directed state government relations and services system improvement for the National Mental Health Association. He performed policy analysis for the National Association of Social Workers and designed educational programs for mental health and addictions professionals for the Association of Ambulatory Behavioral Health Care. That's a long list.
And I'm so young.
True. Aren't we all? And then next I'd like to introduce Dr. Ron Manderscheid, whom I've known for a very long time. When I first met him, he was working with SAMHSA, and I have to put my glasses on because he gave me very, very tiny print to read from. He's currently the Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. And this association represents county and city and local governments and is really the voice of behavioral health in our nation's capital, along with the National Council. And just a few other things he's doing. He's an adjunct professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University. And he's also the past president of ACMA, which is the College for Behavioral Health Leadership. So he's on, it looks like 20 boards, at least. Pretty close, a lot of boards. So he serves on the boards of the Employee Assistance Research Foundation, the Dania Institute, the Frameworks Institute, the Council on Quality and Leadership, the International Credentialing and Reciprocity Consortium, and the National Research Institute. I don't know, that adds up pretty close to 20. Anyway, I would like to turn this over to them, and I have to say I'm really glad you're both here. We really appreciate it. Thank you. Thank you.
Well, good morning. I'm Chuck Ingoglia. It's great to be here with all of you. I'm going to talk today a little bit. They asked me to try to give a Washington update, and I'll leave it to you if it's a place that's far away. Is it not far enough? And we'll talk a little bit about things that are happening there. And I'm also looking forward then to listening to the rest of the discussion because today about how things are continuing to evolve in California. What's most helpful to me, and one of the pleasures of my job, is I get to travel around the country and meet with folks like you and really understand the implementation and policy challenges that you're facing and try to bring those back to Washington to see if we can actually do something about those. So I promise not to be too long. So I think just want to talk about a few things that are unfolding in Washington, and some of this is a moving target. But certainly a lot of attention to what's going to happen with appropriations, lots of talks about different kinds of bills, mental health and substance use bills, and then talk just a little bit about the implementation of the Certified Community Behavioral Health Center demonstration program. So some of this, actually, I didn't change my slides at midnight last night when I got here. Maybe I should have, because it's a moving target, right? We're welcome to the new federal fiscal year. Good morning. And the federal government is still open because they passed a short-term continuing resolution that will keep the federal government open until December 11th. And a continuing resolution means that we take last year's budget and just bring it forward with no changes. And that might be a good thing if you look at kind of where we are from an appropriations perspective. And just a little bit of context, we're operating under this lovely word called sequestration. Does everybody remember that? Which were across-the-board reductions to federal spending, federal discretionary spending, both defense and non-defense. And those cuts then put reductions in the amount of money that was available to the appropriation committees. And so remarkably, both the House and Senate actually, at the committee level, passed funding bills for the Departments of Labor, Health, and Education, which in the House of Representatives, it's been some years since they've even been able to pass a bill out of committee. Just to give you a sense of how much fun it is to deal with sequestration cuts and whether or not legislators want their names attached to voting for things like we'll talk about. So if you look at the House version of their appropriation bill, they eliminated entire agencies. They eliminated the Agency for Healthcare Research and Quality. They eliminated the entire CMS Innovation Institute. They defund the Affordable Care Act. The Senate took a different approach. They just gave everybody a haircut. So they just took a few percentage points from everybody as opposed to eliminating entire agencies. But this is going to be the environment in December 11th. There's a potential that one of Speaker Boehner's final acts will be reaching some kind of budget compromise where we deal with the budget caps and raise those a little bit. And then we have this little Planned Parenthood problem that is complicating discussions about health care bills and appropriations. And then budget reconciliation looks like is going to be moving forward. So this is a lot of things swirling. The big question is we averted a shutdown this week. What will happen in December? Will we avert a shutdown or will we have one in December? And then will we have a full year continuing resolution or not? I would say for us, for just thinking kind of selfishly from a substance use and mental health perspective, a continuing resolution probably ain't bad. Because the Senate bill does reduce the SAPT block grant. It reduces some of the substance use discretionary funds. So a continuing resolution might not be so bad under that circumstance. All right. I thought I had a different slide. I created this cool slide that I don't have here, that cascades, that just picture it. Do you remember the beginning of Star Wars, right? So it was a list of all of these 30 bills that have been introduced, scrolling across the slide in this Congress. Over 30 bills dealing with mental health or substance use issues have been introduced in this Congress. And we have to think about this. On one hand, it's really cool because there's obviously a lot of interest. People are recognizing that the opioid problems that we have, overdose problems that we have in this country need to be addressed. People are recognizing that our mental health system needs continued investment and change and improvement. And the fact that so many bipartisan bills have been introduced is a very good thing. And I'll talk a little bit about some of the particular bills, but then I ran across a quote this morning that I wanted to share with you as I'm thinking about the current environment related to any of these particular bills. And the quote was, "Everything seems simpler from a distance," right? So it's great that we have a lot of interest, movement on any of these particular initiatives. is perhaps a little more elusive. And it's elusive not necessarily because of the particulars of any of these bills, although there are some significant differences of opinion about the particulars. There's just larger kind of political and relationship dynamics. Now, did you ever think that Congress would be different than the kindergarten classroom? Not so different about who likes who talked to who yesterday, and who didn't play jump rope with the other person the week before, and now we're not going to talk to them. So there's some of those kinds of dynamics that occur too. So on the mental health side, there are several bills that have gotten a lot of attention. And it doesn't help that there's a House bill introduced by Representative Tim Murphy, and then in the Senate there is a Senator Murphy bill. So when you say the Murphy bill, you have to then qualify which one is it. These are both bills that claim to want to do comprehensive mental health reform. I think it's be a matter of opinion about whether or not they're comprehensive or reform. But that there is a significant amount of attention, though, to wanting to try to pay attention to the mental health system. And certainly, I think the Representative Murphy bill has done a good job of tapping into the frustration and need of families who want accessible, high-quality care. Now, we could argue about the particulars of his bill, but I think every one of us should be mindful of the amount of energy that bill has created from people who are desperate to get care for their loved ones and support. So I think there are some things in there we should be paying attention to. Now, I'll just comment a little bit about process. So in the House of Representatives, interesting, this bill has been, the Representative Murphy bill has been around for about 2.5 years. And just right before the August recess, the chairman and ranking member of the Committee of Jurisdiction, the Energy and Commerce Committee, made a point that when they got back from recess, so that was in September, that they were going to make this bill, they're doing a mental health bill, a priority this year. And they set a deadline of October 1st of agreeing on what the components of such a bill would be, and then with potential for movement in the rest of this Congress. Now, today is what? October 1st, and they don't have agreement on one provision yet between the Republicans and the Democrats about anything that they could agree on that would be in a bill that they would move. So we'll see what happens. On the Senate side, we have also a comprehensive bill that was introduced, modeled on the House bill, but not exactly the same, introduced by Senators Murphy and Cassidy. And then around like a week later, another bill was introduced in that same committee of jurisdiction, the HELP Committee, Health, Education, Labor, and Pensions. And that bill was introduced by the chair and ranking member, Senators Murray and Alexander, and it was a retread of a bill that they had passed in 2013. It had passed out of committee and then was passed by on the Senate floor, actually, by an amendment to the gun bill, and it was the last amendment that passed before the gun bill failed. And so what was interesting about it is that it did pass 95-2, and as people remind me, it's hard to get the United States Senate to agree that today is Thursday on a vote of 95-2. So, that there was a considerable amount of support for that. Now, I would say, though, what the money quote for me related to this bill is when Senator Alexander got on the floor and encouraged his caucus to vote for it, his reassurance to them was, it doesn't cost a dime. So all it does is reauthorize some programs at SAMHSA, make some technical changes to programs at SAMHSA. That bill passed by voice vote yesterday from the HELP Committee. It will be hotlined in the Senate. And then on the larger comprehensive bill, a date has been set of October 29th for a hearing, not a vote, for a hearing on October 29th. So we'll wait to see what happens there. And then, not because we don't have enough comprehensive bills that have been introduced, Senator Cornyn, who's number 3 in Republican leadership in the Senate, has introduced his own bill that deals with issues related to, the chair on the Judiciary Committee, this bill resides, and it deals with issues related to the criminal background check system, as well as mental health services. It is the only mental health bill so far that has been formally endorsed by the National Rifle Association. I couldn't make this up, all right? So it's also unclear. I think what's good is that Senator Cornyn is number 3 in Republican leadership. He thinks that this is an important thing to do. Some of his staff a few weeks ago had hoped that the majority leader in the Senate, Senator McConnell, would devote 2 weeks of debate on the Senate floor to mental health issues. And I know many of us are waiting for Jesus to come back. So, I don't think it's very likely that the Senate will devote 2 weeks of floor time to discussing a mental health bill, but I am glad that someone of his stature thinks that it's important enough for it to happen. We'll have our Hill Day next week. We have about 700 people coming. We'll be talking about the need for comprehensive reform. I think we can all agree that further investment by the federal government, further direction by the federal government would actually be a good thing. And if we can just keep that momentum going, I think we would all appreciate that. I did want to just also mention the implementation of a bill that was passed in March of 2014, a provision in a bill that was passed, the demonstration program for certified community behavioral health clinics, modeled on the Excellence in Mental Health Act that was authored by Senators Debbie Stabenow of Michigan and Roy Blunt of Missouri. This bill does 2 really novel things. It recreates federal standards for community-based organizations. I call it our Back to the Future idea, that there was a time in this country where we thought it was important that there be comparability in services across the country, that it didn't matter where you happened to go for your services, that evidence-based practices should be available. And more importantly, it then brings with it a Medicaid financing mechanism called prospective payment that would actually make it possible for you to provide those services. Wasn't that great? Because I think this has been our huge disconnect. We want people to do evidence-based practices, and what's been difficult to come up with is the money to actually make that happen. So this creates a new, it provides the same kind of payment mechanism that has worked for federally qualified health centers, a prospective payment that's a bundled rate. This would allow you to do it either on a daily bundle or a monthly bundle, so it gives a considerable amount of flexibility based on the actual costs of providing those services. So planning grants were due August 5th. I think SAMHSA thought that maybe about 12 states would apply for the planning grants. 28 states applied for the planning grants, which I think also is telling, right? That a number of states, and this required the Medicaid director, the mental health commissioner, and the single state agency for substance use all agreeing to file the application collaboratively. And I think it says something that 28 states were saying, our system could be better. And let's spend some time looking at how we could make it better, and whether or not states then choose to apply for the 2-year demonstration program where they're going to be testing this, we'll find out. So states will be, SAMHSA has indicated that October 19th is the date on which they will notify states. There'll be a public announcement about which states have received planning grants, and then states will have a lot of things to do in a year if they choose to participate in the demo. We're working at the National Council on a whole bunch of technical assistance support to help states in that process, to help providers through that process, because there's going to be a lot of things implementing the criteria, establishing the prospective payment system, working on kind of filling in gaps in services, the data infrastructure. So there's a lot of things going on. I'll look forward to your questions, comments, and concerns after my friend Dr. Manderscheid speaks, and it's always a pleasure to be here with you. Thank you.
You can tell from what Chuck said that things need to be straightened out in D.C. And Chuck and I were talking this morning. We decided that if Donald Trump could run for president, we ought to run Chuck here as well, and he ought to throw his hat into the ring. Okay, a couple of things. So first, today is October 1st, and have very good news. Today is the day we are standing up a new initiative to have county behavioral health systems work with local jail systems to reduce the number of people going into the county jails and to improve the linkage of people coming out of the county jails. So I put notices of this out on your registration table for you to pick up, and we'll be back in contact very shortly to do the focus groups to develop this and actually implement this. So we're very excited about this. Let me go ahead here and try to talk very briefly about a number of things. I want to start first with a shout out to Marv Southard, sitting right over here. Marv, the humanitarian, the innovator, and the manager. A lot of work at the county level, a lot of work at the state level, and also a lot of work at the federal level. So we owe you a lot for all you've done. Marv is going to retire on November 6th, and let's give him another nice hand. I also want to take the occasion to recognize Pat Ryan, the interim director, who will be leaving, she tells me, in 4 days again for the second time.
Not that she's counting.
Give her a nice hand as well. Yeah, basically. Okay, so I'm going to rush through a lot of things, spend about 20 minutes here. So the Parity Act brought us to the table in a way that we would not have been in health reform and in the Affordable Care Act had we not done parity. The issue in parity right now is to see that it's actually being enforced. So your challenge to you, if you know of parity violations of any kind, we want to know them in the Coalition for Whole Health, and we want to take them to HHS. There are many instances where people are violating parity. They don't even know they're violating parity. Huge issue. Patient Protection and Affordable Care Act, we're making progress. We've enrolled 11.4 million people in the marketplaces. 16 states are operating their own marketplace, including California. And we've enrolled 6.4 million people in the Medicaid expansion, and California has done a lot in this arena. We have to ask, how did you fare here in this? So it says, very recent statistics, 68% of previously uninsured Californians now have coverage, but 23% report recent problems in paying medical bills. So one of the issues here in the marketplace insurance at the lower levels of income is that the co-pays and the deductibles and co-insurance are very high for people who have very low incomes. So we need to work on that when we do the next cycle of the essential health benefit. I just sent out a few weeks ago the EHB for all 50 states, including California. You need to look at that EHB, and you need to understand what the next cycle will be here. In terms of people enrolled, 1.4 million marketplace enrollees in California. 88% receive subsidies. And probably less well-known, 51% receive cost-sharing reductions on care. 51%, that's a huge percentage, basically. You also enrolled 3.3 million people in the Medicaid expansion, obviously far exceeding any other state. And I understand very shortly, a third of the people in California will be enrolled in the Medicaid system. Some of the insurance issues to consider, we've actually done these analyses on the issue of the co-pays, deductibles, and co-insurance. If I take someone at 150% of the federal poverty level, which is about $15,000 income, and I put them into a silver level plan in a good state, they're going to spend 11% of their income on all of these costs, the premiums, the co-pays, the deductibles, and so on. If I take a person at 400% of the poverty level, they're going to spend 17%. That is a huge issue. We've actually documented these cases here. So need to begin thinking about that, because it would be a tragedy, and to Chuck's earlier point, to have people who actually have insurance and who have problems who then can't access care because they literally can't afford to use the care. It would be an absolute tragedy. Another issue here in the essential health benefit is the pharmacy benefit. Make sure you look at that. We had a lot of problems with the pharmacy benefit the last time in 2012, and expect we will have problems again this time. And we need to move into prevention and promotion. There's a prevention and promotion benefit there as well. It's kind of a null set in behavioral health. We need to move into that area, basically. Now I'm going to go through a couple of national trends here. Your whole meeting here is on integration, so it's very good that I have that as the #1 national trend, I guess, here. Integration with the primary care focus. The ACA provides financial incentives, Section 2703. You can actually get planning money. You can also get 90% money, federal financial participation, for a Section 2703 waiver that allows you to focus in on a particular population, adults with serious mental illness, adults with a serious substance use problem, and so on. If you don't know what a delivery system reform incentive payment is, you need to learn. It's a huge new set of opportunities in the waivers to program money to transform the whole system, the health system and the behavioral health system. I put in here the amount. The providers in New York are getting $6.8 billion in DSRIP payments. So I ask you, are you involved in DSRIP? And if you are not, you need to become involved in it, basically. Full integration means integrated service delivery teams and integrated funding. Integrated service delivery teams and integrated funding. We've done an article on this, happy to share the article. Behavioral health care has not been in synchrony with other health entities in undertaking this reform, and a number of the speakers have already talked about that this morning. Progress in this area that you're going to talk about in this meeting is the most urgent problem facing behavioral health care currently. So I just wrote a paper for a book very recently over the summer, and the problem assigned was, how has the policy of integration developed and how has the practice developed? Well, if you actually analyze this, the policy has been developing over 30 years. We can go back into the 1980s and see the precursors of the policy. Practice is only a couple years old. So practice is going to have to scramble to catch up with where policy is and has been for quite some time. And I think in D.C., to Chuck's point about D.C., I think people in the Congress and people in the department think once they have the policy and they put the money into something, the problem is solved. Not true, not true, because it needs to be translated down at the local level here, basically. Second national trend, value purchasing. Moving to case and capitation rates from traditional fee-for-service. Just yesterday, the U.S. Department of Health and Human Service announced $693 million in grant awards to work on the problem of transition to value purchasing. So the homework here is, who in California got those awards and what are they working on and how do you plug behavioral health into that work? And when I get back, I will get the list of awardees from HHS and I'll circulate that list of awardees. The Secretary Burwell, has set very aggressive targets on the move into value purchasing, and she set the targets for Medicare. By the end of the Obama administration, by the end of 2016, they want to move 50% of all Medicare money into a value purchasing framework, plus 40% will still be in traditional fee-for-service, but have performance measures attached to it. So 50% in value purchasing, 40% in fee-for-service with performance measures. And then by the end of 2018, 90% of every Medicare dollar will be in this system. These are very aggressive goals. So we had the opportunity a few months ago to meet with the Secretary, and we encouraged that the Secretary provide technical assistance to the behavioral health field to help all of you actually begin to make this transition. It's going to be a huge transition. The very first step in a case rate is you got to have decent financial data on fixed and variable cost and know what rate you're operating in terms of your capacity to actually calculate this. And I think a lot of our providers don't have this. So huge issue for us going ahead. Another feature of value purchasing, the traditional model of managed care being external will become internal. You have to manage yourself. If you don't manage yourself in a case rate, what will happen to you? You'll go out of business, basically. It's very obvious. And it's going to move the focus of care from turning the crank and giving more and more care to make more money to delivering better quality care in a more measured way. And I think historically we haven't done that in behavioral health. We'll also promote population health. As you move into capitation rates and you're being paid to manage populations, not just people under care, you're going to have to partition populations into subgroups that have different levels of need. There's a whole huge amount of work that will be coming as a result of that. Third trend, what I would argue, is more flexibility. You are the poster child on the 1115 waiver on systems of care being paid in part by IMD money for community residential treatment. That is a huge gain, and it's a huge movement on the part of HHS to actually put that into regulation and make that happen. We are wondering on the mental health side, there's absolutely no reason we should not be doing something similar on the mental health side. The issue now is not giving people too many inpatient days. The issue is being able to give people any care at all. It's a very different issue than it was 50 years ago when this was created. So there are some potential bills on the Hill that would change IMD for mental health as well as for substance abuse. Home and community-based service waivers, you need to pay attention to this. And particularly right now, the focus is on the IDDD population. They are already into a 5-year cycle of planning where at the end of the 5-year cycle, they have to be able to stand up full service integration, full work integration, and full housing integration. And those plans were already due to HHS last year. A lot of states are still in the phase of negotiating about their plans. This too will come to behavioral health care, although the focus right now is on ID and DD. Federally qualified health centers. Federally qualified health centers have gotten a huge amount of money to move toward integrated care. Knock on their door and ask them what they're doing. Is anybody home here? It's very important. Chuck already mentioned the federally certified community behavioral health clinics. Huge opportunity. I would be very surprised if California does not get a planning grant. I suspect they already know. They had to award the money yesterday.
No, October 9th. It's know your money.
It's know your money? Okay. So in just a few days then. Okay. Very important opportunity. But to speak to that facility, we don't want to create a facility for 1970 in 2015. So we need to figure out how that moves into integrated care. Huge, huge opportunity here. Some assumptions here going forward in what I'm talking about. If you think the pace of things was fast last year, it's going to be even greater next year because the administration is winding down and wants to achieve things before they go out of office. So you need to pay attention to that. Counties are going to confront the issue of developing integrated care systems and engaging in self-management. And finally, the California carve-out will end. Say it again, the California carve-out will end in favor of integrated funding. So you probably will have maybe up to a 5-year process to do the transition, so you need to start talking about the transition literally while you are here. I put in here a table, which I'm not going to go over, just need to know it's in the overheads, that you can use to analyze where you are in the integration process. And Model 1, 2, and 3 are kind of the 3 levels you can be involved in. Model 1 is simply treat, refer, but Model 2 is bidirectional integration, Model 3 is full integration. How are you doing access? How are you doing integrated care delivery? How are you doing your payments? And how are you doing your outcomes? Where you stand in each of these will tell you and help you know where you need to go going forward here. So in all of this, we don't go hat in hand from behavioral health. We bring the concept of recovery, and we're the only people who bring the concept of recovery into the healthcare system. So if I have high blood pressure and I go to my physician, he or she's going to give me a pill. And then they're going to measure my blood pressure and say, did the pill bring my blood pressure down? That is not recovery. Recovery would be asking me, do you eat too much salt? Are you overweight? Do you have too much stress? And getting into some of these life issues that I know San Diego County has gotten into. We also bring trauma-informed service delivery. And we're the only people who bring that. That's a huge gain in behavioral health in the last years, in the sense that we didn't really understand trauma-informed service delivery prior to about the year 2000. It's all developed since then. We kind of had a magical model that mental illness kind of just appeared. Well, now we know 3/4 of mental illness is due to trauma. And a lot of the trauma has to do with issues in the social and physical determinants of health. If you are poor, you are discriminated against, you have poor health education, and on and on and on. That then plays out in your life in various forms of trauma that make you more likely to have illnesses. And also peer support. I would predict in 5 years, 1/4 of the workforce in behavioral health is going to be peers. Partly of necessity, because we aren't ramping up our training, but partly because it is what we should be doing, and peers are very effective service deliverers, and for many reasons. I will expect to see peers in county jails, in emergency rooms, in federally qualified behavioral health clinics, in integrated delivery systems, health homes, and so on. Huge, huge opportunity. So some questions for you going forward. I'll talk through these, and there's another set I'm not going to talk through here. Homework for Friday night. How can I extend my limited human resource capacity? You have to be confronted with that already right now. What role will peers play in this? How can I work with local community colleges to begin bringing people on in paraprofessional roles? All these things need to be addressed. How can I show that behavioral health care contributes to the value of service delivered? In an integrated delivery system with the case rate, we're going to be part of the case rate and part of the delivery, not the whole game. We have to show value here. And it's very important that we be able to do that in a credible way. How can I integrate prevention and promotion services? And that might be primary prevention or secondary prevention. If I could delay the onset of heart disease in the United States by 5 years, I probably would save $100 billion a year. That doesn't mean I prevented heart disease from ever happening, but I'm simply delaying. If I could delay the onset of depression in people, or delay the onset of schizophrenia, or reduce the severity of these disorders, I can change the nature of that system. How can I work with my local community to implement community interventions? So in the future, and the example here, now students are now coming to me saying, well, I want to end up with a joint degree in social work and public health. Where can I go to get a joint degree? Well, there actually are a few places, but you can count them on one hand. Those students are very smart because those students see where things are going to go. That's exactly where it's going to go. Public health is going to be integrated into these systems. It has a major role here. In Oregon, it already is integrated. So part of that is, in public health, implementing community-level interventions, working with people as groups rather than working with people as individuals, and I think behavioral health will be doing a lot of that. I'm not going to go, this is your homework for Friday night when you go home. I'll not go over these questions. So what would we expect here? And I'll stop with this overhead. If we actually did all the things I just talked about, we would expect the longevity of our public clients to improve. As I stand here in 2015, We have not had any impact on the fact that people are still dying 25 years early, people with behavioral health conditions. We've had no impact on that number. That is a tragedy, basically. We would expect recovery to improve. We expect more people to have a life in the community where they have a job, they have permanent housing, they have a social support network, and so on. And we would expect their community tenure to improve their full community participation. Part of my vision is that in the future behavioral health system, consumers and peers will run the system. There's no reason that shouldn't happen. We have absolutely brilliant people who are peers. We should also expect the implementation of prevention and promotion protocols to improve personal and population health over the longer run. And it's much harder to quantitate that and say, well, I'm going to spend money now to help you 20 years from now, but we have to start beginning to think about making those linkages. And most work in prevention and promotion that will be done by us. Because most issues in prevention and promotion are actually behavioral. So huge opportunities here, huge challenges. I know you're all up to the challenge, so thank you all very much here.
Well, we certainly got some challenges from you two. Thank you so much. We have a few minutes left for any questions that you might want to address. There's a couple of mics back in the back, if you wouldn't mind just going to the mic and so we can all hear you, because this is kind of a large room. Hey, good morning.
Good morning. Dave Pallon with Mental Health America of Los Angeles. I guess this is a question for Ron. Ron, you mentioned the aggressive targets that the administration has for moving towards a value payment structure for Medicare. I was just wondering if you could comment on when we might see a similar push for Medicaid, because I think that most of the providers here have much more investment in that system than in the Medicare system. Not that we don't provide Medicare services, but it'd be a much greater system for us. Thanks.
Very good question. And because the Medicaid system is a federal-state system, rather than just a federal system, the Secretary cannot set goals in the same way. That doesn't mean that the Secretary will not be working with your local state Medicaid director to Medicaid director to set goals for California for you. That's one issue. Another issue is we have a huge dual eligible population in behavioral health. Probably a third of the people who get Medicaid also get Medicare. So you need to be concerned about that, because the Medicare component of that population is going to be pulled into the system basically completely within the next 4 years.
And maybe I would just add that while CMS can't do it directly, there are other ways through the Innovation Center that they are incentivizing states to do this. So there's Ron talked about the DSRIP money that's flowing, but there are also these SIM grants that states are getting. And I know several states that have gotten SIM grants are working on common performance metrics across their entire healthcare system, behavioral health, primary care, other specialty care, so that they're having kind of common expectations across healthcare. So that's the other way that that's happening.
Mark Southard, LA County.
Hold on. Nicola's getting it.
So this is for both of you, but this is kind of in response to Ron's slide about the challenges and opportunities coming up. And I'm thinking of the slide that starts with the we need to develop new workforce and we need to engage communities. And as I was thinking about that slide, it seemed to me that maybe the biggest challenge and opportunity is the last point of engaging communities in this work of transformation that needs to be done. and that if we don't start there as our starting point, the other three on the slide will be very difficult to accomplish. So from both of you, I wonder what guidance or advice you might give us on being able to root this work that we're trying to do in actual communities and their needs as they see it.
Excellent point. And I guess I would cite an example from Washington, D.C. In Washington, D.C., Ward 7 and Ward 8 have the absolute worst statistics that you could imagine. Very low rates of graduation from high school, high rates of drug use, very high rates of incarceration, very high rates of HIV/AIDS, and on and on and on. We went into those communities and we actually sat down with people living in the communities and said, can we work with you? Can we work with you on some of these basic things? You have a food desert. How do we work with you on a food desert? And very interestingly, they wanted to be organized. We start with assumptions about people in these communities that are not true. We need to disabuse ourselves of those assumptions that we have disorganized communities where people don't care. They care. They care a lot about their children. They don't want their children exposed to drugs, murder, et cetera, et cetera. There's a huge opportunity if we simply go out and reach out in an organized way. In that instance, we worked with Catholic University of America because it's near those wards, and Catholic University of America actually provides support for these community development activities pro bono as part of its social justice mission. So you can begin putting together some partnerships that will work in these communities, and you'll see that you'll get a tremendous response from the community that literally will overwhelm you, basically.
The other example I would throw out is the other Washington State, which is using its new 1115 waiver to create accountable communities of health. So they're not going to use Medicaid money to pay for housing or food, but they're making performance measures part of those contracts that's incentivizing Medicaid health plans and providers to be responsible for that, to figure out local solutions to improving those things. So that's another, I think, a really kind of interesting model.
Thank you.
Yeah.
Alfredo Aguirre, San Diego. In regards to federal legislation to reform the mental health system, regarding the feature of ridding the IMD exclusion, is there bipartisan support from your intel on that?
Well, I would say two things, right? So we very proud of what's happened in California and then the subsequent guidance that's come from CMS regarding opportunities within 1115 waivers to build comprehensive substance use systems. There was another regulation released this year that deals with the regulation of Medicaid managed care plans that also provided coverage for IMDs for psychiatric care, both for hospitals and crisis residential in 1115 waivers for mental health. So CMS has already done something comparable on the mental health side through that's going to be allowable in the same kind of mechanism in lieu of through 1115 waivers. Yeah. I would say regarding IMD legislation, there is not bipartisan support for simply eliminating the IMD exclusion. And can you guess what the number one reason why there is not bipartisan support for that? It starts with M and ends with I. Well, why? Money. The Congressional Budget Office says that repealing the IMD would cost about $400 billion over 10 years. It becomes a non-starter with legislators.
But we don't want to leave the IMD money on the table as we move to these integrated systems. So we need to stay on this and make progress on this issue, even though total progress is maybe impossible. Yeah.
Well, but again, you think about what CMS has done in the last year. They have a statutory prohibition that prevents them from paying for IMDs, and now they have said for both mental health and substance use, we are giving you permission to do this in a very public and way. So I think we should be mindful of the win that we have achieved on that side.
Good morning. Bill Arroyo, Los Angeles. In your short list of federal legislation, I wasn't sure that you mentioned the federal prison reform package bill. That's the Cornyn White House bill, so it has bipartisan support, which I think is worth mentioning, which may have implications for us. And secondly, we would very much be chagrined if we didn't mention a piece of legislation by a California Congresswoman, Napolitano, and that's the Mental Health Services in School Act, which has been reintroduced, I think, for the fourth consecutive time. However, not only is she a co-sponsor, but there's also a Republican co-sponsor.
Yeah. Yeah, sentencing reform is on the top of my paper here, but I forgot to talk about it. Certainly, there is a lot of interest in sentencing reform. It'll be interesting to see if they can pull that off this year. My fear would be if it's not done before the end of this calendar year, when we get into an election year, it will be a lot more complicated in next year to move forward. And certainly there's a lot of substance use legislation that I thought I had a slide in there. The Comprehensive Addiction and Recovery Act, CARA, which has broad bipartisan support in the House and Senate, and many other bills related to improving kind of our nation's response to the opioid epidemic. Now, the fundamental problem all these bills have is what's the vehicle for moving them. So there's a lot of interest. We're going to continue to put a lot of pressure, and there's a lot of good opportunities out there.
So, an additional comment about the opioid epidemic. Secretary Burwell has made the opioid epidemic a major focus of her administration. So there will be a lot more development activities over the next year and a half while she's still the secretary. And there's a lot of movement in that area, including, a strong movement toward medicated assisted treatment and other things that we need to be paying attention to in this field. The field is developing very rapidly because there's a spotlight being put on it by the secretary, and potentially there's federal legislation that would be very helpful in this regard.
Gigi Crowder, Alameda County, and I just wanted to acknowledge that I had a conversation with you, Mr. Manderscheid, around what we could do to improve outcomes by using faith approaches.
Yeah.
And you shared with me that that was an excellent place to start. And so we have been building mental health friendly communities across the state of California. It's been pretty much limited through a grant through Each Mind Matters to the African American community, that model. But I know that Los Angeles has done some work, so has San Diego, in reaching out to the community. Do you have any additional insights for steps forward we could take to reduce stigma around mental health and build up leadership in faith communities?
So I think there are new developments in that area. I just very recently attended a day planning meeting on the role of faith communities in recovery and behavioral health at the Carter Center. And I don't think anything has come out on that yet, but will be coming out, and there will be work groups formed to try to move that to the next level. And we could have a very long conversation about things that could be done here. Spirit is a very important thing in people's lives, and spirit can mean many different things to many different people as a fundamental piece of life. But also in the service system, many people don't come to behavioral health. They go to their local church or synagogue or temple, and they might even talk to the secretary there. So we need to build some linkages we haven't had historically, and we shouldn't be frightened of the faith community. In the end, they're our friends in this regard, basically.
I wanted everyone here to hear you say that. Thank you.
The only other resource I would mention is that there is a mental health literacy program called Mental Health First Aid, and it does have a component that's directed for faith communities, engaging them in mental health education.
Okay, we have time for one more question. Mary.
I was going to say, I've been told I am the last person, so yes, Sandra. Mary Hale, Orange County Behavioral Health Director. Chuck and Ron, thank you for your presentation. Always good to hear that federal perspective from both of you. I specifically wanted to ask Ron about a comment that you made. We, of course, have recently received approval of our 1915B waiver, what you were referring to as the carve-out. And while there was some rumor, concern that we may not even get This current one, we were quite pleased and worked very closely with DHCS to obtain a 5-year waiver. And you mentioned that you thought that would be the last time we get that. And I'm just wondering, where does that come from? Have you heard anything specifically to indicate that? Tell us more.
Well, I think the whole move to system reform and integration and value purchasing move you away from carve-outs to fully integrated money. And I think that's what the Secretary is trying to do, setting these aggressive goals. And, you know, there will be goals set for Medicaid as well. So I would say, you know, you're on probably the last cycle you will have of carve-outs. That doesn't mean you're not going to be there, but it means you should start planning for the new world where you won't be paid through carve-outs, but paid through integrated money that is done in case rates, basically. And we at the national level, and Chuck's organization and ours and others, need to work with local people to help them understand how this is going to work. That's why we asked the Secretary for technical assistance for everybody in this area, because we don't want behavioral health to be left behind on this issue.
I have a more cynical answer.
Okay.
Which is the health plans have a lot of money and they're very aggressively lobbying state legislatures to get rid of carve-outs because they want that money in their contracts. And there's certainly a lot of movement around the country to do that, and somehow this magical thinking that if we integrate the money at the site of care, care will be integrated. And I think that is the huge disconnect, is that somehow we have to have the integrated money in order for care to be integrated. If you look at a state like Colorado, which has had a very strong carve-out, there are over 150 integration pilots happening around the state. You go to a state like Minnesota that has had a strong carve-in for over 15 years, there is virtually no integrated care happening at the site of care. So it can happen. It doesn't necessarily, you know, I'm not saying, you know, one or the other excludes the other, but there's got to be a lot of thought put into actually making that happen.
Well, thank you for those answers. I'll just say we are trying to be proactive here in California. We're working with our Joint Powers Authority to look at payment reform, to be prepared. We're pleased that we have the 5 years to really look through that. And as you said, Chuck, we want to have integrated services, and it doesn't necessarily mean that it has to be the funding has to be integrated. But we appreciate hearing your perspective and want to be as prepared as we can be to move forward on that. Thank you.
Good.
So we're going to take a break for 15 minutes, but before we do, would you join me in thanking?
Always good.